Good morning, ladies and gentlemen. This is my pleasure to be with you. Unfortunately, I can't be there in person, but I'm sure we can successfully debate on this issue remotely. This is my disclosure, and my role in this debate is to argue that patients with recent direct oral anticoagulant exposure should have drug-specific anti-TNA activity checked prior thrombolysis. This is strongly associated with observational data that RTPA or TNK can be offered with low risk of ICH in such patients, which is a portion of our capsule. And this is something I would like to question and to show you arguments that these data are actually too weak to generate any guidelines for routine use. So if you say yes to the capsule, it means that if you want to thrombolyze patients on anti-TNA DOAC, of course with its recent exposure, you have to measure anti-TNA activity first, whereas if you can't measure this, you shouldn't administer RTPA or TNK routinely. Routinely is a key word here. Obviously, we don't discuss special rare cases. We discuss standard care. Don't use single special cases to prove the routine, because this is among biases in the theory of evidence-based medicine. I like that name. This is called survivorship bias. And of course, we discuss current state of the art because, as we all know, there are trials pending on this issue that will largely increase our knowledge about this, and definitely after they are finished, the standards will change. The opposite view is you can routinely use thrombolysis in patients with recent DOAC exposure without any anticoagulant activity check because it is apparently safe. Then the answer would be no, meaning you don't have to test DOAC activity even if DOAC was taken in a large dose and shortly before thrombolysis. But, and this is my role in this debate, to show you that we actually don't know if this treatment is safe because the data are too weak to generate any guidelines for routine care. I would even say that some conclusions from these data are unjustified. Moreover, the pathophysiological data strongly suggest it might be unsafe. Please let me to start from a few basic statements for the completeness of the story. Anti-TNA anticoagulants do change function of the coagulation cascade towards bleeding site. They are effective in stroke prevention, similar to warfarin. The level of anti-TNA activity is associated with prevention power and with stroke severity. The combination of therapeutic dose of low molecular weight heparin and RTPA is strongly associated with bleeding risk, including fatal ICH and outcome after stroke, and this combination is simply contraindicated. And please take into account mechanism of heparin here. The pathophysiology, something I've already mentioned. So works suggesting that DOAC RTPA TNK combination is safe are chaotic in the terms of evidence-based medicine theory, and therefore they're useless in the terms of guideline formation. And my task is to show you why these data are useless in the terms of formatting guidelines. I'm not criticizing this data because they are hugely important. I'm just showing that they are not enough to liberate in practical routine use thrombolysis in DOAC patients. And I listed for you 5 major papers. Of course, there are many more in the literature, but these are among most frequently quoted, and I prepared the list of methodological imperfections for each of these papers. But first, here is the list of selected major problems that are characteristic are present actually in each of these papers and many other papers on the issue. So there was no randomization, just observative character. Third point is very important. Actually, if you analyze this in detail, there were really few patients included into these studies with known, certified, real pathophysiological risk of bleeding, high risk of bleeding. There were also major, I would even say unacceptable differences in characteristics of included patient populations and in management protocols. So in some centers, there were even no institutional protocols, just individual arbitral decisions. Of course, there were selection bias confounding. And now let me to be boring for a while, because mathematical or methodological arguments are sometimes boring, unlike single case emotional arguments. So this is the first work, and major limitations here are listed in this slide. So very important issue is that there was, and repetitive issue actually, was that there was indication bias. There was inadequate sample size and powerful subgroup analysis. There were baseline imbalances, residual confounding despite adjustment defined here. There was unblinded subjective outcome assessment, imprecise measurement of exposure, and the missing data. There were a lot of missing data in actually each of these works, but they were in this work, they were handled using simple complete case analysis. Finally, there was lack of adjustment for multiple testing. This study employed a target trial methodology to mirror RCT, but in fact, it reminded retrospective and of observational character. Again, there was confounding by indication. There was mismatched reversal cohort with baseline imbalances between the groups. A lot of incomplete data, like for DOAC plasma level. And really significant variables were missing for a substantial portion of the cohort, like 33% of the IVT group, 60% of non-IVT group. And again, this missing data were handled using simple complete case analysis. There was lack of adjustment for multiple testing too. This was just a narrative review with no systematic rigor. There was an underlying publication and selection bias. This study lacks a risk of bias assessment. And by the way, as authors acknowledge themselves, the conclusions are derived solely from case reports and observational studies. Major limitations for this study are listed here. So let's discuss a few. There was a broad inclusion window, probably the major problem herein. So there were patients presenting even up to 72 hours after symptom onset. They were included to encompass all acute decisions. Again, confounding by indication, insufficient power to assess safety outcomes in key subgroups. And again, as is in every paper, there were baseline imbalances, lack of multivariable adjustment, lack of adjustments for multiple testing. Functional endpoints were measured solely at discharge, and again, unblinded subjective assessment. And the last, large paper, frequently quoted, well known. So the major problem here were large institutional guideline differences that included not only time of administration, but also doses of thrombolytic. Importantly, there were few patients with real pathophysiological high risk of bleeding after thrombolysis, because there were few patients with anticoagulant, confirmed anticoagulant activity higher than 100. And again, there was confounding by indication, subjective outcome assessment. There were baseline imbalances, unmeasured confounding. There were lack of adjustment for multiple testing. Interestingly, there were no white matter lesion in neuroimaging in these patients. And as you know, this is characteristic strongly associated with the bleeding risk and hemorrhagic infarction. And most patients were treated late after the onset. And still keeping discussing this paper led me for a little bit of irony. And this is the quotation of the abstract of this paper. So please read through the yellow marked portion of the text. So if one do conclude that thrombolysis is safe after full and recent DOAC exposure based on this data, based on the data from this paper, then also one need to administer a DOAC before thrombolysis to decrease the risk of bleeding. Of course, again, I'm sorry, this is simplified and of course only ironic, but anyway, it would be absurd. Okay, and this is just a short interlude just to show you that our team, our group is experienced in the issue. So we just recently published the paper showing association between stroke severity and outcomes in patients with high therapeutic anticoagulant activity. Yes, and this is an extraction from EU clinical trials register. Here is our study, our trial, our safety trial testing the safety of the combination of andexanet alpha and ATPA. Yes, and now it's time to address a few arguments used by those against testing. The first one of the most commonly used, is low accessibility of drug-specific anti-TNA testing, and there are questions like, will you not treat otherwise eligible patients? As I mentioned before, this is survivorship bias and cannot be an argument. I like that statement, which is not mine, which is quoted, that limited availability does not invalidate the clinical relevance of a test. It's obvious. It only reflects a system-level constraint. Ladies and gentlemen, in our center, we set up and been using anti-10A, by the way, also anti-2A testing for several years, and the accessibility for that is 24 hours, 7 days. Easy and helpful test, and it was really relatively easy to set it up in our lab. I'm sorry, let me for a kind of irony again, simple irony, and just to ask the question: would you administer a thrombolytic in warfarin active patient when your INR machine is broken? Of course, it's not the same, but just take that into account in your reasoning. So in fact, if you say yes to the capsule, you will still administer thrombolysis to the majority of patients and only avoid few major bleeding cases. You just increase the safety, and that if your lab is efficient as ours, so the testing and you have the result within 20 minutes. And another argument against testing: you don't know the time of DOAC administration. Indeed, in many cases, you don't have that information. But it doesn't mean that the result you have is useless. The point in the time when you generate the highest bleeding risk is at the beginning of thrombolysis administration. And you do have real-time drug-specific anti-TNA activity from this time point. Of course, you don't have full information, but you do have a lot from it already. This is important for some countries. In some countries, the law is the characteristic of the product in medicine. So here is extraction from European Medicines Agency for tenecteplase, and the expression is very clear here. Tenecteplase is contraindicated in patients receiving effective anticoagulation, full stop. What do the expert groups and societies say? Of course, it's probably less important for us because we directly discuss data and we don't discuss what others think about the data. But nevertheless, to complete the story, ESO says yes for this capsule. No thrombolysis with recent DOAC exposure unless you measure anti-10A activity. And here is a guideline, a very recent guideline, as you know, from the American Heart Association and American Stroke Association. And the information here is very laconic. So actually, the Americans say, let's wait for better data. There's no point to generate routine thrombolysis for patients on DOAC. And to end up at this point in the history of the issue, which is very important because we are pretty sure that pending clinical trial will change our recommendations. But at this point, I do recommend to say yes for the capsule because test before thrombolysis in patients with recent DOAC exposure, because pathophysiologically we know this might be unsafe. There's no evidence in the terms of the evidence-based medicine theory that it is safe. These data are too chaotic to generate any guidelines for routine use. Routine testing towards drug-specific anti-10A activity is not complex to set up. Single time point information on the activity or drug concentration carries important, useful, although not complete, but already important and useful information to assess the risk of ICH. Take into account the law, take into account the opinion of societies. These are all yes for this capsule. And finally, maybe there will be time in the second portion of our discussion, I ask different application of AI, what it would do, and in each option, including options with using just scientific data, it said yes. It said yes for testing anti-10A before thrombolysis. Thank you very much.